first partial nephrectomy was performed by Zarni in 1887, but it never gained widespread popularity because of the poor results. He did it for renal cell tumor, but it is also been done for duplex kidney with symptomatic non-functional moiety, like in a reflux cases, or in
what
a
else is Zarni famous for?
So he's famous for the retractor, sir. For rectal
we still use it in partial nephrectomies.
Yes, sir.
Okay.
Plus, he was very famous at his time for oncology, sir. He was doing tumors.
Yeah, that's right.
Then, even partial nephrectomy was practiced earlier for stagnant calculus with a complex anatomy in 1950s onwards. Then, at that time, it was believed that if only the calculus is removed from the anatomical predisposing risk factors for the calculus formation will still remain after removing the calculus, causing more recurrence. So they were happy doing partial nephrectomy, removing the anatomical predisposing factors also, like lowermost calyx, the reservoir, and renal plaques were acting as adhesions for the calculi. Plus, they considered that this calyx where the stone is unhealthy, and as per the so this prefer doing partial nephrectomy and taking out the defective calyx. This was only possible because kidney is anatomical suitable for segmental resection given by the Xrays in 1954. Because of its segmental supply, between these segments, there was no collateral arterial blood supply, while there was a free venous anastomosis. Then in 1966, Papan Thadis and Swiney published in BGO.
Swiney,
sir.
Volume, someone.
Can you increase the volume a bit?
No, sir.
They compared outcomes of
Morning.
So, in 1966, they compared the outcomes of partial nephrectomy with pyelolithotomies and nephrolithotomies. And they did 44 lower pole nephrectomies and upper pole 4, and even bipolar in 2 cases. They found mortality, secondary nephrectomy, and post-operative leak much less in partial nephrectomy cases. But 14% cases had wound infection, which responded well to antibiotics. So the present study investigated 2 types of recurrence of calculi. The true recurrence of the calculi on the already operated side, which was much less in case of partial nephrectomy, and the false recurrence due to residual calculi following the operation. So very interesting to note that they concluded that spontaneous passage of recurrent calculi following the partial nephrectomy is almost 10 times higher than the pyelolithotomy cases. Thereafter, Anderson in 1974 and Marshall in 1975 contraindicted the partial nephrectomy due to loss of the renal tissue. Coming to the second paper, sir, Dr. Rose from Bradford Hospital published a study of 227 partial nephrectomies in 1977 in BGU. They performed partial nephrectomy not only for difficult anatomy but also for smaller stones. Then similarly, in the previous, as per the previous study, they had more incidence in the lower pole partial nephrectomies. Intraoperated, after they removed the stone, they took Xrays of the exposed kidney to keep a record and follow up and compare for recurrence.
How is this taken, Kamal?
Sir, after removing the stone to the exposed kidney, sir.
Okay. How do you take it? What is the technique? What do you use?
I'm not sure they were having at that time fluoroscopy or not. The
Fluoroscopy won't help. You need a hard film because resolution is so much better and radiation so much less.
XYO technique, sir.
What is XYO?
Remove the entire kidney, place it in the X-ray table and take X-ray and put it back.
And then put it back, is it? Oh, XYO unit. No. It's all done with the kidney where it was. Nothing is removed. We first used to use the conventional smallest X-ray film available, wrap it and do all kinds of things. Then we got these dental plates, which were meant for dental X-rays. And so X-rays would be taken with the dental film and the conventional X-ray machine. Subsequently, the dental X-ray machine would be brought into the theater and films would be taken with that. Least contamination and very good resolution of the area you're interested in. Dr. Ganesh might have other tricks up his sleeve.
About exposure of kidney, X-rays?
About post partial or the pyelolithotomy X-rays for residual stones.
We actually, when you looked at the history of these X-rays, the Kodak company designed specific X-rays called Kodak Exomat. And it had a little bit of a sort of a hole on one edge which would fit against the hilum. And we couldn't get this. We couldn't get this at all in India. But these were radiographs. They were placed against the kidney and then you brought the C-arm machine and you would, or even the portable X-ray and take X-rays. When we started doing these operations in Vellore, what I did was I went to the dental department. If you remember, nowadays they've got this pantograph and very small X-rays, they're fancy. But those days, they had an X-ray, a small X-ray, which you could actually, they would use for exposing the teeth.
It was a 4x6 plate.
Correct. So what I did was, I first took it, I put it in sterile covers and took it and sterilized it. Then I opened it and went to microbiology and told them, please make sure that there's no bacteria here. And they said there's no bacteria. So then, like all these things which are double packed, we double packed it in polythene, sterilized it, exposed it to our regular sterilizing procedure. Nothing happened to it. And then we would put it against the kidney and take these X-rays. At that time, CMC, you would be surprised, did not have a damn C-arm, And this was, we had top orthopedic surgeons of the country working there, and these fellows were fighting and they didn't want a C-arm. So this portable X-ray machine would come in. You go to the quad and they would bring this thing inside and, positioning the patient and positioning of the X-rays and all that was a big dance. But we got very good X-rays and you could make out where the stone was, and then we would take, only problem was we had to take many X-rays. Because it was not screening, you had to take it, then they will develop it, come back, then you put needles and find out where it is, and then you go and make a nephrectomy and hunt inside the kidney for the stones. So it was an interesting period of time when we were trying to battle with stone disease in these patients. So, yeah. And of course, now things have changed.
We got our C-arm in 1999.
I had to fight with the administration and I said, I want 2 C-arms. And the director said, no, I said, I want 1 C-arm for urology. And then he said, you buy 2 C-arms because you will have a fight. And sure enough, because the orthopedic firms realized the value of the C-arm, and then there would be a drama, and we bought it. They didn't lift a finger to do anything. I moved heaven and earth and got the C-arms, and then we said, this is primarily urology because we paid for it. We paid for a technician. So the machine belonged to us, but we said, okay, we will loan it to you guys at this particular time. And when the machine comes in a large institution, you put it out, and you have two departments fighting, we say we have punctured the kidney and we are going to wait this. You have to wait. Those fellows would have put the screw and all that and say, wait, the drama will go on between your two churches.
We have 3 Siams in St. John's, and yet there is a fight every day.
Every day there's a fight. No, that's the problem. Yes. All these teaching institutions suddenly have realized the value of the Siam. Anyway. So it's a very interesting period of time when stone disease was being treated. And we still haven't won that battle. I had actually told about these 2 articles. John Sweeney was the chief of urology in Newcastle. And Sweeney did a lot of work on partial nephrectomy and subsequently did a lot of work also on urethral stricture. So Johansson and Sweeney operation for lay open described by this fellow. And they were all the dadas of urology at that time, and a lot of pioneering work. So that data has not been surpassed at all. You may say, yes, this is the best way to take out the stone, but have you prevented recurrence by any of these methods? You have not. This is the only operation which has shown that the commonest site of stone is lower pole and the recurrent site has dropped significantly after the lower pole has been ablated. You may agree, you may argue that, oh, I removed the kidney, I removed part of the kidney, all that. That's a different matter. But when you look at recurrence, nothing to beat this data. That's why I said, have a look at this. It's all historical, but it does make a lot of sense today, when you look at stone disease.
I think that philosophy of nephron preservation killed it.
Yeah, you're right, absolutely. Yeah. The only thing we don't have, or I haven't been able to find, is the histology of the parenchyma of the lower pole which was ablated.
We've got a few.
Yeah, but
most of them showed chronic pyelonephrotic
yes, that's right.
and calcification within the calyx.
I was more interested to see if there was any evidence of glomerular sclerosis, because if that occurs, then that amount of parenchyma is gone. But somehow we've been able to find the histological breakup of that parenchyma. That's the only thing.
Correct.
So the X-rays of the exposed kidney were taken at operation site and they were recorded to compare during follow-up to differentiate true from the false recurrence. Then the mean follow-up was about 12 years. So the recurrence rate after partial nephrectomy increases.
Now I'm going to ask you a question on statistics, Kamal. Go back to the previous slide. You say mean follow-up was 11.9.
Yes, sir.
1 to 34 years.
Yes, sir.
How will you understand whether this means anything at all? Or whether it has an impact on your assessment and on your conclusions? Because statistics is a funny thing. The numbers could be skewed one way or the other.
Yes, sir.
So how will you find out whether this is a natural series or whether it is skewed?
It's normal distribution but skewed.
Sir, they give a graph, no, sir, and they will, in which year, how much frequency was there?
No. You have just this one figure. Okay, what will you do with the graph?
So I can divide it in middle and see which side the graph is more enhanced, more skewed.
Okay, so what is it called?
So distribution says how the data has been distributed.
Histogram, sir.
Hey, Praveen, histogram is a depiction. Okay, this is not depicted on a histogram. This is called, there are two things when you do this: coherence and deviation. So as close as it is to a central point on that bell curve which is drawn, that means it is close to natural prevalence. As long as it moves away from the central point, it means that there is more divergence and either the number is not enough or different factors are affecting the distribution. You've not checked across populations or you've not checked across ages and so on. One of the things here you'll find is they're not, I mean, at least on the slide, we don't know what the ages were. Okay, just a little bit of statistics because I can ask you in the exam.
Yes, sir.
And that might definitely come in theory.
Another rule of thumb is that many of these things are stenine. If you mentioned the word bell-shaped curve, so the stenine is the word that is used for these graphs, for this depiction. It's like your normal flow rate pattern, and if you see that most of the patients fall within that stenine range, and there will be a few on the outliers which are starting off at the graph like that. So most of the patients will be in the center. So maybe we don't know what that distribution was, but if it was there, then age distribution, everything, the follow-up 11 years, most of them, about 100 whatever patients,
would have been
not right in the center. So it makes difference. The outliers, 1 year, 34 years, maybe 1 or 2 cases. Most of the things are in that bell-shaped curve, if you look at it.
But when you look at the mean of 19, it looks at it seems a fairly good distribution.
It's 11 part.
Sorry?
11.
Carry on.
Okay. So the recurrence rates are after partial nephrectomy was increasing with time on follow-up and is the same in the operated side as well as in the unoperated kidney. So which indirectly suggests that recurrence doesn't decrease with the partial nephrectomy, sir. It is the biochemical events occurring in the urine, which is the main etiological factor.
You are talking of Anderson's paper, huh?
This MS Bose, sir, 1977.
Rose, huh?
Rose, sir.
Okay, Bradford.
Then he categorized the etiology into metabolic, anatomical, infective, and idiopathic. Idiopathic, in which the other causes were not ruled out.
Not idiopathic, idiopathic.
Idiopathic, sir. Then sir, they also noted the calcifications. Like 22% of these kidneys form more stones who had calcifications comparative to the 12% who didn't have calcification, which suggests that renal calcifications promote stone formation, sir. And although the stone formation is primarily a biochemical event occurring in the urine, the anatomical factors may decide where the stone will develop. That's it, sir, today.
Now you see, you have case 2 and the paper 2, paper 3,
Yes, sir.
which are coming to different conclusions,
Yes, sir.
somewhat. How do you reconcile these?
Reconcile, sir, both were in favor of partial nephrectomy, suggesting that if we remove the defective calyx, then recurrence will reduce.
That is an anatomical theory.
Yes.
Right?
Second,
The second is a biochemical theory.
biochemical theory.
So how do we reconcile this?
So both believed in biochemical, but
No, you can believe in anything.
Yes, sir.
Scientifically,
Yes.
how do you reconcile this? Because eventually, if you want to prevent stone recurrence, you must know what is contributing the most.
So, of course.
It's actually a good challenge for you.
Yes.
Someone can take it up as a dissertation based on these 2 papers and start your own observations if you're doing the nephrectomies.
Yes, sir.
Okay, see, we are halfway. We don't know whether it's anatomy or biochemistry.
Yes, sir.
If our goal is to prevent stone formation, we have to find out which contributes the greater degree. Lot of effort. We may be searching for the holy grail, But when we find that out, we'll know what to do.
Yes, sir.
Whether to intervene biochemically or whether some more of the anatomy has to be cleaned up. Okay,
Yes, sir.
just a thought. Dr. Ganesh can add.
No, I think it's good to go back on some of these old data and then try to see if we can reinvent it or try to challenge it. These are good things actually to look at. Somebody has made some point here. That's the beauty of science anyway. You challenge a concept, and that's how it is. At least in medicine, you can do that.
So far.
We'll